Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So I'm just going to roll through these fairly quickly. You guys will, you can, of course, interrupt me if you have any questions or anything is unclear. So we're going to talk about the history of emergency medicine a little bit. This picture you see is actually a left-sided thoracotomy, which occurs in patients who have penetrating injuries and have lost their vital signs. So this is a life-saving procedure. I don't know how well you can see this, but there's a hole in the heart right here that's being ligated. Anyway, just an interesting picture and one of the more dire procedures that is done in our trauma bays in the United States and in emergency rooms throughout the country. Emergency departments, it may be surprising to younger generations to know that in the old days, like back in the 50s and 60s and 70s, before the development of emergency medicine as a specialty, emergency rooms were staffed by just random doctors with any myriad of training. It could be a neurologist, could be a surgeon, could be a cardiologist. It was whoever was working or moonlighting in the emergency room. And there was no specialty training specifically for the types of patients that would present to the emergency department. So in 1968, the American College of Emergency Physicians was established to try to address this. The specialty was formed in 1979, and the ACGME granted emergency medicine independent specialty status in 1988. So not that old, really. So when I was training, the doctors who were training me were the first generation of emergency physicians. And it's very interesting to hear how things have changed and pivoted from their upbringing, their training, to mine, to now, as I'm teaching the next generation, how things have changed and how they pivoted. It's actually a fairly interesting dynamic in such a short time frame. So the first resident graduated in 1969. First residencies were established at the University of Cincinnati in 1970, and the first residency association was established in 1974. You can see how emergency medicine residencies have grown dramatically, almost exponentially. In 2000, when I was coming up, there were 971 PGY positions, that's postgraduate year, so emergency medicine residents. Now there are over 2,500 residency positions in the United States. When we talk about specialty selection, I think it was interesting to note what are some of the types of pathology that we see in the United States. And you can see a list of the top 10 causes of death in the United States. And if you look at this as an emergency room doctor, I look at this and I see every day, I see patients with heart disease, cancer, strokes, COPD, accidents. I see upper respiratory tract infections. Right now, you could add COVID to that pneumonia and influenza slide. I see that every day. I see diabetes every day. I see mental health every day. I see end-stage renal disease every day. And I see chronic liver disease and cirrhosis every day. So all of these patients funnel through American emergency rooms on a daily basis. It's a massive amount of healthcare that is being provided by emergency departments. But I just worked a shift today. I saw probably 20 patients. I know I saw 2 cancer patients. I saw 1 acute stroke. I saw several patients with COPD. I saw 2 trauma alerts. So 1 car accident, 1 guy was beaten by some assailants. I saw a ton of COVID, as you can imagine. Probably 50% of the patients I saw had diabetes. I saw 3 mental health patients. I saw one patient on chronic dialysis and two patients with renal disease. And I saw one patient with ascending cholangitis, which is a biliary and liver emergency. This patient was jaundiced and very, very sick patient, septic from his infected gallbladder. So that's kind of a day in the life of an emergency room. And I came home and my wife asked me how my shift was. And I was like, yeah, it was kind of a normal day today. That's a normal day. There wasn't anything unusual or outlandish. It was pretty straightforward. And that's kind of a typical day in the life. And then continuing along with those more interesting cases, the ones that kind of grab the headlines, you'll see all these other things, these other prosaic sort of mundane kind of things, like a 25-year-old with an undifferentiated rash, spousal abuse. You'll see homeless patients who come in because they have nowhere to go. It's 10 degrees outside. They know the ER is open, it's warm, they can get a meal there. There may not be a shelter available. And so they'll come in for no other reason than they either need TLC, they need just to talk to somebody, they may have mental issues, they may just want to get out of the cold and get a meal. And sometimes that's our role in those cases. And you know, personally, I have colleagues who find that objectionable. For me, I feel like anybody who comes to the emergency room and asks for help gets it, which is one of the really cool things about emergency medicine, and one of the things that I didn't really become aware of till I started practicing in residency. There are several federal laws that mandate that, which I think are, again, well intentioned, but there are downstream consequences. We won't sort of belabor the point there. But one of the coolest things about my specialty is that anybody who comes to my hospital campus and asks for help gets it from my emergency department, whether they can pay or not, whether they're from this country or not, no matter what. And I think that that gets overlooked sometimes. And it's one of the things that I think emergency medicines have an enormous amount of pride about. And I certainly share in that pride. But you'll also see patients with, chronic migraines and back pain, things that aren't exciting in the sense that they're going to be immediately life-threatening or life-altering, but these patients are miserable. They're very uncomfortable, and providing relief is part of the job. Certainly, that's why we all go into medicine, right? We want to relieve suffering and care for the sick. So another cool thing about emergency medicine is that you can practice almost anywhere in the world. And you can fashion your practice in so many different ways. You can work in a big city. You can work on an Indian reservation in the middle of the Midwest. You can work in a community suburban hospital, which is where I currently practice. You can work at a teaching university, a big multi-center tertiary care center, have every subspecialty known to man, work with some of the brightest and most brilliant clinicians in their fields. Or you can work in a community hospital and practice out on your own, which is where I work. You can travel all over the world. Locum tenens means you just sort of show up and you work for a short period of time and you travel, maybe a 12-week contract. You can see parts of the world that you never thought you would see, travel all over the country. There are enormous international opportunities. US residency trained EM doctors are incredibly sought after. You can work in New Zealand, you can work in Africa. There's just so many different ways to get your emergency medicine career on track. There are, of course, third world opportunities. And interestingly, cruise medicine tends to be an emergency medicine friendly. They like emergency medicine doctors because of the length and breadth of our training and the fact that we can kind of handle all comers. One of the things, again, that I really liked about emergency medicine was that you are able to make an immediate impact on patients' lives. Even if it's something as prosaic as a small laceration, the patients come in, they're obviously terrified. They're worried. They're worried about the cosmetic implications. They're worried about the pain, and you can fix them literally right then and there. It could be, again, a sprained ankle. It could also be an open tibia fibula fracture that you have to reduce at the bedside. You will see life-threatening injuries and illnesses that require immediate action on your part, where literally seconds count. And that is enormously rewarding when you are able to ply your trade in such a way in such a patient. You have an undifferentiated patient population. You literally see the 99 percenters to the 1%ers and everybody in between. There are two types of people in the world. You either like the challenge of, I have no idea what's going to happen in the next 45 minutes, next 35 seconds, or you hate it. And if you hate it, emergency medicine may not be the career for you. If you love it, if you like the idea that I could see anything today, I could literally have a mass casualty event. I could have, I could have gunshot wounds. I could have rollover MVA, which is a car accident. I could have a sick and dying child, which is the worst case you can imagine. and everything in between. And I find that incredibly exciting. There are innumerable procedures to do. We do spinal taps, we do thoracotomies, which was our first slide. We do multiple intubations where we manage the airway. We treat strokes with TPA, and we get immediate results sometimes with that treatment, which is pretty exciting. And we provide the safety net for American healthcare. Again, if anybody comes to our campus and asks for help, no matter what their insurance status is, we will help them to the best of our ability, which I think is incredibly exciting. Um, Again, I'm a former athlete. I love the team approach. My nurses and techs, we are shoulder to shoulder taking care of the patients. We are super tight, just the way a ball club would get, or a fraternity or a sorority might get. Once you kind of struggle together and you're sort of kind of have this feeling like you're out there fighting the good fight. So I love that team approach. We also tend to be very patient advocate friendly. We are the ones calling up the insurance companies, demanding that they allow us to do these particular tests, maybe as an outpatient. For instance, if a patient's had back pain for months and months and months and just kind of getting stonewalled by their insurance companies, we will pick up the phone and say, look, we're in the emergency room. We're going to get an MRI today. And because I believe that this patient needs it and it needs to be happening right now, or stat. And so we'll be advocates for our patients. There are numerous academic opportunities. You kind of have a shift work set hours. So for instance, today my shift was from 6 a.m. to 2 p.m. And I kind of knew that at 2 p.m. I'm done and I don't have to carry a pager. I'm free and clear. I can walk out of the emergency room. Not to say you don't leave some of yourself behind. You always do with difficult patient encounters. But it's nice to have a set start time and a set end time. That really helps with family planning and your work-life balance, which is super important to young physicians. I think one of the things that I see young students do and pre-meds and residents, they're so laser focused on the job that sometimes they forget that work-life balance is crucial. And physicians have a high rate of suicide, and it's unacceptably high. And we have to do a better job as a medical society of nurturing our young physicians and understanding that work-life balance is actually a good thing. It's not a sign of weakness. The way it was taught to me when I was a resident, if you wanted to go home and take a shower, you were a wuss. That's no longer the case. We understand that work-life balance is absolutely crucial to healthy and productive physicians. And like most specialties, it continues to evolve. We are establishing new parameters, new metrics. We're adding new subspecialties and new fellowships. For instance, ultrasound and simulation are becoming new emergency medicine subspecialties. So there's some downsides, right? It's not all fun and games. You deal with some difficult people. You deal with the mentally ill. You deal with intoxicated, violent patients. You deal with criminals. That's when they get shot up by the police, they bring them to the emergency room. And as you can imagine, those patients are not exactly thrilled to be there. So, and sometimes the flip side of that insurance coin is trying to find follow-up care. For instance, somebody comes in and has congestive heart failure, and they need to see a cardiologist and a family doctor to get on an appropriate regimen, but they're uninsured. And then I am not a primary care doctor. I'm not skilled. That's not my training. I don't feel comfortable providing that type of care for patients, but they have no other place to go. So they come to me, and then it can be sometimes a difficult thing. It's not that I don't want to care for them. I don't enjoy it. It's just, I don't have that skill set. That's not really what I'm trained to do. So I feel like the patient's getting short shrifted, as well as, they're really not getting the care that they need. One of the really hard parts about emergency medicine is we work in in a fishbowl. We are constantly second guessed. We are making snap decisions with very little information, very little medical history sometimes. Sometimes it's downright misleading information. Patients are sometimes not completely honest with us, as you can probably imagine. And so we have to make a decision and a call and a treatment pretty quickly. These patients are only in our grasp for maybe a few hours. Then the patients either get discharged to a specialist, or they get admitted to the hospital where further workups reveal other illnesses or a completely different diagnosis. And then, that dummy eye doc thought it was a heart attack. Clearly this was a dissecting aortic aneurysm, after they've been in the hospital for 3 days and had, a $10,000 workup. Now we have new information, and then you are judged sort of critically. And that either bothers you or it doesn't. And for me, it does not bother me at all. Look, I'm here in the first couple of hours. I'm going to do my best. I'm going to try to get as much information and treat these patients to the best of my ability. But I'm going to send them now, once I've determined they need to be admitted, they can go to see some sort of ologist and let them take care of it and find the final diagnosis. I'm okay with not making the final diagnosis. Sometimes that can be hard. I like the Sherlock Holmes sort of chase, like trying to figure it out. But I don't like all the necessarily the legwork to kind of run everything to ground. That's why I like to stay down in the emergency room and let the folks upstairs kind of work it out. All right. So the lifestyle, EM is often referred to as a lifestyle specialty for the reasons that you do work well-defined shifts. You don't really take call, generally speaking, although depending on your group size and what have you, if somebody calls out sick, obviously you got to get somebody there. So you may have a call shift where you're just kind of around if somebody doesn't make it. You can also work as much or as little as you want, which is kind of cool. It's pretty well paying. We're kind of in the middle of the bell curve of physicians, maybe a little bit towards the higher end in terms of salaries, but pretty close to the single standard deviation from the middle of the bell curve with regards to salaries. But you do work evenings and nights, you work weekends, and you work every holiday. I'm working Thanksgiving and Christmas this year. And that's time away from family. I missed a lot of ball games for my son. I missed a lot of family things that I couldn't go to. It's good and bad. So that's why two sides of the same coin. Not everybody has a Lamborghini. I'll just be honest. So there are a couple of different areas of specialty that you can go into in emergency medicine. And that may be a little bit unfamiliar to some people. Some of the biggest ones are pediatric emergency medicine, toxicology, which is super cool. All emergency medicine doctors are experts in pediatric emergency medicine and toxicology. Most of us, because of our long-standing relationship with EMS, we get a pretty good familiarity with the EMS systems and what have you. And then sports medicine. Sports medicine is another branch of emergency medicine. You can do a sports medicine fellowship after completing your emergency medicine residency. But the reality is that I see all of these cases in my regular general EM practice. So unless you have a deep and abiding interest in that particular specialty, I would say go for it if it's really something that you specifically are interested in. You want to spend your life in a tertiary care center taking care of subspecialty emergency medicine cases. For instance, if you were to do a pediatric emergency residency, you would almost certainly be working at a tertiary academic center because that's who has pediatric emergency rooms. My personal home institution it's a pretty big hospital. We have 500 beds. We have a 70-bed ER. We see about 80,000 patients a year. It's pretty high census. We see a lot of those are kids. About, I think, 30% are children under the age of 21. And so I didn't really need to do a fellowship to continue to see sick kids. But if you wanted to work in that environment and specialize in that, then pediatric emergency medicine would be a great choice. Same with toxicology, which I think most EM docs find super cool. It's just one of the fascinating offshoots of emergency medicine. I remember my toxicology rotations and my mentors in toxicology extremely fondly. They were just incredibly brilliant people in the biochemistry and the social aspect of toxicology, and the poison patient is just fascinating. But if you want to be a general emergency medicine doctor, you're going to see poison patients. You don't need to be a toxicologist to see those. So it's kind of an interesting dynamic there. All right. So let's kind of switch gears here and we'll talk a little bit about what you guys will do if you're EM hopeful and you're a first year, second year medical student. So it's always good to join the EM interest group affiliation. You'll get a lot of good advice about programs, about how to shadow your local institution. You'll get opportunities to observe. Sometimes you can get plugged in with a summer research project with some of the EM faculty who might be doing some clinical trials or some research. But I would say that at this point in your first and second years, I'd still keep your eyes and ears open. There are other changes. You don't want to go in focused too much on one specialty. I think that's a mistake, and go ahead and just be open to other things. In your third year, you're going to see patients in the ER because you're going to be rotating on your general surgery, peds, internal medicine, et cetera. And they all often get admitted through the emergency room. So you will actually go down to the ER to see the patient on your off service or your other service and observe them. So in your third year, when you're down in the emergency room, make sure you take time and get to know some of the residents and become friendly with them and express your interest. And you'll get, they'll kind of help you navigate through the emergency room. We're all pretty welcoming. We want to help all of our students and residents, um, when they're in the emergency room, have a seamless and smooth encounter with their patients. But by spending a little bit extra time getting to know the third years, you can really help kind of grease the skids a little bit. All right. So residency programs, lots of residency programs. There's actually a slight dichotomy in the field. Should we continue to add residency programs? From a purely business standpoint, you don't want to glut the market with emergency physicians. You want to kind of keep them a relatively prized commodity. But there are some money-making issues, and cynically, I think there's some other forces arrayed that are creating more and more residency programs. But right now, there are 269 programs, and as I mentioned, there are about 2,500 residency positions in the national match. Emergency medicine is interesting. There are two ways to become board certified. You can do a PGY 1 to 3 years, so a 3-year program, or a 4-year program. Most of them are 3-year programs. The 4-year programs tend to be located at academic facilities. I went to the University of Virginia, a very high academic tertiary care center. It was a 3-year program. Personally, why take 4 years when you can do it in 3? I don't know. The 4th year gives you anything that I don't feel like I missed anything by not going a 4th year. Sometimes if you want to do if you want to do research, or you're interested in perhaps a particular track, maybe you can preempt yourself for a fellowship, that kind of thing. Maybe the 4-year programs are worthwhile. I know many people who went to 4-year programs. They were very happy with their training. There's really no right answer there. It's really just what a personal preference, personal choice. There's no specific advantage to the extra year, though, for what it's worth. All right. And there's a couple combined programs like EM-PEDS. You do a 5-year program. EM-IM also is a 4 and 5-year program. And then you can also do internal medicine and critical care, which is a slightly longer track. We do a lot of critical care in the emergency room, but if you do the fellowship, then you're probably going to be working in an ICU somewhere, taking care of the sickest of the sick. So if I could just switch gears and talk about choosing a specialty, I think it's one of the hardest things that you'll encounter as you become an upperclassman in medical school. I think one of the best pieces of advice I got was, when you're working on a rotation, you might want to gravitate towards the specialties where the people who are there, the residents and the attendings, are kind of like you. They have the same worldview, they have the same sort of mindset. So for me, when I was in emergency room, when I was trying to decide, and I was in the emergency room, I felt like all the men and women I worked with were kind of like me. They kind of liked their free time. They were kind of fun loving. They were easygoing. They had fun at work. They were badasses academically. They knew their way around the body. They knew their way around procedures. They were super calm during the worst, gnarliest emergencies. But man, they knew how to play too. They would go out and they were riding bikes. They were doing extreme sports, surfing, all the things that I kind of like to do. So that kind of was, and that's slightly nebulous. You don't necessarily have to be a surfer to be an EM doc, but there are, people who don't do that. There are bookish type EM docs too. But I just felt like that was where I fit. I just felt at home in the emergency room. I like the chaos. I like the pace. I kind of thrived in that environment. And I thought the docs who were residents were kind of like me. We kind of saw the world the same way, a little bit cynical, kind of smart alecky. But I found that the commitment to care and the commitment to being at the bedside and doing their best for patients and their families was absolutely 100% woven throughout the entire specialty. And I really like that. You'll go through this period where everybody will badmouth other specialties. The EM guys are just triage nurses. The neurologists are all nerds. That kind of stuff. Surgeons don't care about anybody. They just want to cut and get out of there. That's all bogus. It's not true. And so I would ignore that. If you really want to get the inside scoop about a particular specialty, listen to the people who are doing it, and they'll kind of give you the straight dope. They'll tell you. If you come to me and work with me, you'll be like, "Hey man, what do you not like about emergency medicine?" I'll tell you what is not great about it. To me, the scales are enormously balanced in the favorable position, but I'll tell you the straight dope about things that you may not like. And for instance, some people hate the fact that they don't know what their day's like, and they could never thrive in that environment. I have friends of mine who are doctors in other specialties tell me that all the time. They're like, I don't know how you do it. I would go crazy. I'd kill myself. Where for me, I was like, man, I would hate to show up every day from 9 to 5 and be on call every third night, doing the same thing over and over and over and over and over again. That would drive me crazy. So emergency medicine is the perfect fit for me. But whatever specialty you choose, definitely commit to it if you can. Now, we all make bad mistakes. So if you get into it and you realize that you've made a bad choice, go ahead and punch out, though, certainly. So these are all true cases. These are cases that I had. So I'll walk through them pretty quickly. So you're just minding your own business on a sleepy Sunday morning in your community ER when the HEAR radio squawks with an ambulance en route to your facility. You're a level 2 trauma center. There's a 19-year-old male who's been extricated from a low-speed MVA. So EMS arrives with a 19-year-old male on a backboard. He's quite agitated. He's writhing on the gurney. The EMS crew and local police department are holding him down. He does not have a C-collar in place. They tried to put it on, but he kept taking it off. The initial report that you get from your EMS provider is that the patient was involved in a single car motor vehicle accident. Incidentally, this occurred in the same neighborhood that I actually live in. And he was able to tell me where in the neighborhood this happened. There's a curve around where the gate comes to let you in and out of the neighborhood. But the patient was found underneath the dashboard, and he was extricated from the car without difficulty. There was no prolonged extrication. He was awake when the EMS folks got there. As I mentioned, he's quite agitated. There were some beer bottles noted at the scene. Okay, so you get a stat portable chest x-ray and a pelvis x-ray. For those of you unfamiliar with reading chest x-rays and pelvis x-rays, those are normal. Normal chest, normal pelvis. So because he's so agitated and you think this patient might be either injured severely or have a significant head injury or a C-spine injury, you want to get control of this patient. So you want to intubate him quickly. So you sedate him and intubate him. And you put him in a C-collar to protect his cervical spine. You cut his clothes off, you look him overhead until you roll him on his side. You don't see any real signs of external trauma. There are no ominous findings. There's no deformities. There's no bruising. There's no bleeding or lacerations. His initial vital signs are a temperature of 98. His heart rate is 110 beats per minute. His respirations are 20, and his blood pressure is 110/60. So you place 2 IVs, and now you're ready for your secondary survey, including labs and images. So you get things, you turn around, you kind of talk to your charge nurse about what the plan is, and all of a sudden you turn around, you hear the monitor going off, and his vital signs are changing right in front of you. So his heart rate has gone up to 147 beats a minute, and his blood pressure is dropping to 90/45. Those are both markedly abnormal signs in a traumatic patient, or in any patient, quite frankly. So those are indicative of a patient who is becoming shocky. Mm-hmm. And the term shock gets misused a lot, but for our purposes and what clinicians use shock to mean is that the patient is not getting adequate tissue perfusion. So you happen to look at his neck veins and they are bulging. And as you listen to his heart, which you could hear pretty well initially, despite the noise in the trauma resuscitation bay, now his heart is becoming harder to hear. So this is a classic presentation for an immediately life-threatening issue called pericardial tamponade, where there's an injury to either the heart or the great vessels surrounding the heart. And now there's blood filling up the sac around the heart, which, if not arrested immediately, will choke the heart off and cause a cessation of heart electrical activity. The heart will stop. So this is an ultrasound picture. So the big arrow shows this big stripe of dark fluid between the heart right here. This is the heart. This is the atrium. And this is the pericardial sac right here. So this should be right here. Instead, it's right there because this is all blood. It's full of blood. So now what? The CT techs are calling you saying, hey, where's that trauma patient? We're ready for him in scanner. But his vital signs are continuing to decline, and you are just putting away the ultrasound probe when his heart stops. So this is a blunt trauma arrest. The survival rate for blunt trauma arrest is essentially 0. So these patients are typically coded for a while, but they are almost never resuscitated successfully. So we start CPR. We place a central venous catheter. Now what? Drugs, blood, you want to give up. Giving up is not flippant. That's a lot of times if patients lose their vital signs after a blunt traumatic arrest, the trauma surgeon will say, this is not a survivable case, and we will cease resuscitative efforts. But this was a 19-year-old kid who came in alive. So you're going to obviously not just raise the white flag here. You're going to try to do what you can to save this kiddo. So as I mentioned, survival rates for blunt traumatic arrest are not good. Remember that first slide? That was a thoracotomy. If anybody wants to crack his chest, that's not a bad idea. And actually, we considered that. A pericardiocentesis is where you actually place a spinal needle under the xiphoid process into the heart to drain that pericardial fluid. That will buy the patient time to get up to the OR where you can repair the lesion and prevent the heart from being squeezed to death. So these were our options. We were going to do a thoracotomy or a pericardiocentesis. Fortunately, we got a pulse back. That was supposed to be a gift, but I don't think it came, or I don't think it worked. I don't know why. So anyway, so we got a pulse back, so we didn't have to make that decision because I was going to put a needle into his chest and drain his pericardial sac. That was what I thought was the next step to do because I thought he had tamponade. If I'd have done that, I would have killed him. If we'd have cut him open down there, he would have died. So we would have done what we could have done, but he would have probably not survived. But we were lucky that we were able to buy enough time to get a pulse back with epinephrine and atropine and good CPR and good resuscitative efforts.